I'll tell you. Now.
Perfect. Buenos días a todos nuestros amigos en Latinoamérica. Muchas gracias por estar conectados. Muchas gracias. Estas van a ser las únicas palabras que voy a poder decir en español. Como ustedes saben, esta vez tenemos a grandes invitados de Turquía y Grecia, así que nuestro seminario en forma extraordinaria va a ser en inglés. Les voy a, como siempre, pedir que mantengan, por favor, sus cámaras encendidas en todo momento y sus micrófonos apagados, ¿ok? Y después van a poder hacer las consultas. Si se sienten cómodos con el inglés, por favor las hacen. Por favor, si no se sienten cómodos, dígalas en español y nosotros podremos traducir las preguntas. Así que sin más, vamos a comenzar. Okay, good morning for everyone in South America. And I think good afternoon or good evening for our friends in Europe, Eastern Europe, who are connecting now. So this is a very special occasion. We are the ESD Latin American group, and we have held 3 seminars just now. The first one was about the experience of top ESD operators in South America, in Japan, with the real masters like Dr. Yamamoto, like Dr. Yahagi, like Dr. Toyonaga. Then we have our second seminar about the ESD lives and the ESD centers when you can learn with Alberto Herreros de Tejada from Spain and Sergio Rubel from Chile. And then we have the experience, the starting experience of some operators like Dr. Luis Marin from Peru and Dr. Andrea Alfaro from Costa Rica. And this is our 4th seminar, a very important one. We have a real masters of the technique. This is a real honor for me. Thank you very much, Dr. Bassioukas. Thank you so much, Dr. Aslan. As I have told you, I have been following your career from the internet, from Congress. You are really top class ESD operators. So this is a real honor for me. I know how busy you are, but we are here. Thank you so much. So Dr. Stefanos Bassioukas is from Greece. He's one of the top ESD operators from Greece and of course from Europe. And he will talk about challenging cases of upper GI ESD. And also we have Dr. Fatih Aslan. He is the one and only colorectal ESD or a non-Japanese ESD master. He is the endomaster.
Thank you. Thank you so
He
much.
is the endomaster. So he will talk about the colorectal ESD. So our schedule for today, we'll have presentations about 20-25 minutes. And then we have a space for questions. Please feel absolutely free to ask in Spanish if you need, and we will translate for our speakers. So without any more to say, I would like to ask to Dr. Stefanos Bassioukas to share his screen with us. And please, Dr. Bassioukas, begin your presentations. Thank you very much.
Okay. Thank you, Andres. It's a great honor for me to invite me in such a panel. Of course, my friend Fatih is a very good friend of mine. He's the master in Europe. Okay, I'm a sub-master. Okay, and also I saw the Professor Edouard Despo, who is also a master in ESD in Europe. Before entering my presenting my lecture, I first saw the first ESD case in Europe back in Netherlands at 2009, when Professor Yahagi was invited by Professor Paul Fokins, and he resected and blocked with a new technique. We never saw this in Europe, an esophageal lesion. And from that time, it was an obsession in my mind. I had to learn to do this thing. So all things leading me to go to Japan and find out what was about this. And of course, to learn it and if it was possible to perform it, because from learning to perform actually in patients it's not very easy. So in Japan, they are specialized in upper and lower GI. In Europe and in general in the West countries, we don't have this possibility. We have to do ESD in every possible case. This is a disadvantage for the rest of the world because the incidence of gastric cancer is very low. So we have to handle all cases. This is my team in Athens. I'm working in a private hospital. I used to work in a public oncological hospital, but due to financial crisis in Greece, I had to move for better endoscopes and better instruments to the private sector. So this is my team. Back in 2011, I first went to Japan in Kitasato University in the city of Sagamihara, at the Tokyo prefecture area. I stayed there for 3 months to learn the basic steps for endoscopic submucosal dissection. And then in 2013, I've been in Shizuoka Cancer Center for 1 year under the Fuji Mountain. And I had the privilege to be trained by the sensei Hiroki Ono. Hiroki Ono was one of the first persons that got the idea of endoscopic submucosal dissection. He has his own special technique, which I will show you in the upper GI cases. He's the inventor of IT2 knife, and he's using this knife for upper GI cases. And after spending a very good time in Japan in these 2 periods, I got to go back home, and there the problem begins, because in Japan it's the real land for doing advanced endoscopic techniques. But what is happening to our centers back home? So I got at the first minute many problems. First of all was the scope technology. In the Japanese centers, they had not only image-enhanced endoscopes with technology like narrow body imaging, but they have optical magnification, endoscopes with water jet. They are all these set up in Japanese centers are set up to do advanced diagnostic and advanced therapeutic endoscopies. And that was a problem in my country. Also, the second problem is that for a beginner for ESD, it's a long procedure. So when you are practicing in a busy endoscopic unit, you have to do the ESD case at the last cases of the day. So I ended up to do my ESDs at the afternoon when the nurses were leaving from the hospitals, and I will have to persuade my colleagues to stay with me and do ESD cases. And of course, the problem is, of course, the reluctance from doctors to refer cases. And not all gastroenterologists and endoscopists were familiar with endoscopic submucosal dissection and advanced techniques. But things is changing if you are insisting in your obsession. And as you see, from 2012, in 2 years we performed 55 cases in an oncological hospital, and we reached in 2017 186 cases. By the end of this year, we will reach only for this year, for these 2 late years, 467 cases. I think this is a high volume number for you, but if you can set up a reference center, these are very usual numbers. And what is the way to do this thing? Of course, we have to set up a dedicated department, very close to the endoscopic one, but a dedicated department for advanced endoscopic, for advanced diagnostic endoscopy, and of course for advanced therapeutic endoscopy. This year, we set up a new department. It's an endosurgical department. All our ESD cases are performed into the surgical room in a dedicated endoscopic department in surgical room, because the level of the difficulty of the cases is getting every year very high. So we have to preserve the safety of the patients. And of course, you have to go to many local congresses, national congresses, and show your job, and of course for the other doctors to get know about the new techniques. I think from 2018, my country, as far as I'm concerned, the new generation of endoscopists are quite familiar with the role of ESD in the recent times. What is the numbers according to the location of the human body? And of course, the most usual cases are colon cases for non-Japanese countries. Our volume is about 472 for colon cases, 185 gastric cases, and only 51 for esophageal cases. And let me go straight to the point. And this is the typical example of a gastric ESD. This is for a beginner one. It's a lesion located in the antrum at the greater curvature, which is the best practicing for practice ESD first cases. And I'm using the IT2 knife, as I told you. I've been trained by Hiroki Ono, the inventor of this knife. So I've learned to work with this knife very good. So in order to use IT2 knife, it's a little completely different strategy comparing to other blunt tip knives like dual knife or flash knife. So we have to do a pre-cut and then enter the ceramic bowl of the insulated tip into the hole we dig, and then we do a full circumferential mucosal incision around the marked area of the lesion. Then we have to do a good trimming at the edges, as you can see from the video. In this way, we retract the lesion, and of course we dissect the muscularis mucosa fibers, and then this gives us the space to enter the knife and also have a better dissection plane. What is specific about this knife, the IT2 knife, is that you can do, of course, in a horizontal plane the dissection, but it's better suited to do in a lateral fashion the dissection. As you see, we're going from the distal to the proximal side, and then we dissect the submucosal layer. Of course, the blade of the knife is very far, is about 4 millimeters. So you can dissect very quickly a good volume of fibers. Of course, the capabilities of this knife in terms of coagulation is very good. You see, we can coagulate almost every vessel inside the stomach, the gastric wall, and we can do in a very quick way the dissection. You can see a small bleeding here, and how we can stop this immediately with a knife. It has a tremendous, powerful coagulation effect. Let me go further. And this small lesion, it was about a 3 centimeter lesion, can be resected in this location. Of course, it's a very easy one, in about 15 to 20 minutes. Unblocked with IT2 knife. But there are, of course, the stomach is not so easy in some other locations. For example, if we have to deal with lesions in the lesser curvature above the gastric angle, there with IT2 knife, we do in the same fashion this fully circumferential incision. And of course, sometimes it's very difficult to have a direct visual of the dissection plane. What can IT2 knife give us is that we can also do the first steps of dissection in a long position of the knife, because it is an insulated knife and it's quite difficult to induce perforation. In this way, we can hook the fibers in a long position with a knife, and then we can dissect this in order to get inside downwards from the mucosal flap, and then to in a quite visible manner have a very clear dissection plane and do the dissection. This case is done in a retroflex position of the endoscope and the rare approach. It's quite easy with IT2 because we are not fearing of perforation due to the insulated tip. But of course, the strategy is completely different. We have to move around the endoscope in order to hook the fibers and with a pedal to activate the diathermy and cut the mucosa. Of course, our ally in all ESD cases is gravity. So we have to take care when we start the dissections in order to have a better lifting of the lesion from gravity. And this is crucial in every ESD case, in gastric, and of course, mainly in the colon cases. And of course, if you have a very good lifting, a very good cushion of the submucosa, with IT2, you can do in a difficult occasion ESD in very, very short time. This lesion was about 7 to 8 centimeters, and it was done in 35 minutes with IT2. Of course, it's not the first attempt of ESD. Of course, it's about the number of, I think, 300 number ESD. You can do this in 30 minutes. Okay. But there are buts in stomach. Okay, stomach is the first location, the easiest location to start practicing ESD. But there are some special characteristics in the stomach also that may render an ESD case a little bit difficult. And as investigators have seen, is that greater curvature lesions is quite a little, have a special characteristic of the tissue that renders the ESD a little bit difficult. First of all is that the approach of the endoscope is not so easy with a retroflex position. And after this, the tissue of the gastric wall is not so thin. The mucosa is a little bit thicker, and most of the times there is fatty tissue inside the submucosa, which is not a good thing for diathermy. It's not very easy to do a dissection and have a clear plane. So in these cases, sometimes I'm switching to hook knife in order to do a good trimming of the lesion at the edges, in order to reduce the bleeding, because of the fatty tissue has many hidden vessels inside. So if I am trying to dissect in the upper parts of the submucosa, I will end up with so much bleeding. So I'm trying with a hook knife to do a dissection very close to the mask layer, of course with precautions, not to induce a perforate. And sometimes we have to think about counter traction techniques in such locations. And one very nice technique and very easy technique, one is the clip line method, or clip let and flows method, or clip snare method. Everything you can do in order to retract the anal side of the lesion and have a better dissection plane. This is the main problem in endoscopic procedures, and of course for ESD, is that the counter traction is relying only to gravity. So we have to invent some simple ways in order to do the ESD in a shorter duration and have a second hand as soon as possible. So sometimes we can face too much fibrosis underneath the submucosal layer. So in these cases, it's better to switch from the IT2 knife. It's a thick knife, so you cannot do a very precise dissection. So you have to change to a dual knife or a hook knife for a better and a precise one. So I think in all endoscopic departments that they want to do ESD cases, they have to be familiarized with every possible knife and every possible technique, because the characteristic of the tissue and the location of the lesions are very different every time. So as I'm telling to my colleagues, we cannot order the cases. We have to do the case as it's coming to us. In the esophagus, of course, squamous cell carcinoma is not, the incidence is not so high in my country and in Europe, I think, but the adenocarcinoma of Barrett esophagus is very, very usual. So, of course, the technique of EMR ligation is a very good one, but for highly suspicious lesions that may harbor submucosal invasion, I think the best solution is to proceed to unblock resection with ESD. So in these cases, for Barrett adenocarcinoma, after marking the lesion, it's the first incised site must be the gastric side, because this facilitates the finish, the good finish of the dissection, and you have in order to find what is the anal side. If you are approaching the lesion only from the oral side, from the esophagus, you sometimes it's very difficult to find where the lesion is ending, and of course the dissected specimen is a little bit floppy, and then things is getting a little bit not so clear. So first thing is, it's better to delineate the gastric wall, the anal side, and do a good streaming at that side, in order when you dissect to find the incised mucosa very, very easily. Of course, for these lesions, I'm using dual knife, and I will show you IT Nano later. And after doing this, we switch to the oral side and doing the incision in the oral side. Dual knife is a fantastic knife for this, for esophageal ESD. It's very, very precise for cutting. I'm using the dual knife jets with jet function, and 1.5 millimeter model, not 2 millimeters. 2 millimeters is best for gastric ESDs or even for rectal ESD cases. And as you see, we have a very good plane. This is not a fully circumferential incision. We do only the anal and the oral, and as we proceed at the middle of the lesion, we can do a lateral mucosal incision in order to have a homogeneous dissection plane. Of course, if the lesion is too big in length, you see that there are a vessel. I saw that with the dual knife retracting the blade, we can coagulate the vessel, so we don't hit the vessel with the blade because this may cause a bleeding. So it's better to pre-coagulate the vessel before dissecting. So in these cases, if the length of the lesion is very high due to the floppiness of the resected specimen, it's better to have also a good retractor there. And what is more simple than insert a clip and a line and with the outside of the mouth of the patients, and grab it with surgical forceps, and with the gravity it can retract the specimen and give us the optimal dissection plane. As you see how is hugging on the lesion and how easy it is, and sometimes it's better to, in order to do a very, very fast dissection, we can switch to IT Nano and take out all the fibers in a very, very quick manner. This was an adenocarcinoma in a buried esophagus with unblocked resection in less than one hour, something like this. So for squamous cell carcinoma, this is a case I performed this June. It was the toughest, I think. This is the lesion is occupying the whole perimeter of the esophageal and is located at the cervical esophagus. So we have to resect like a tube all the esophageal wall. Of course, for squamous cell, we have to, of course, to delineate very good the outside healthy tissue. So we have to use a dye chromoendoscopy with Lugol staining, iodine staining. And in these cases, I think that the simplest way is the tunneling technique. Fatih has shown us how tunneling technique is doing in a colorectal very big lesions. And also this is, I think, the same for esophageal cases. So after marking the anal and the oral side of the lesion, okay, then we proceed to mucosal incision of the anal side in the perimeter of the healthy tissue. The location is a little bit difficult because of the narrow space of the cervical esophagus there. But except that it is an easy ESD. The esophageal ESD, I think it's easy. The toughest cases are colorectal cases that Fatih Aslan will send us later. Okay. So after doing this fully circumferential, we proceed to the oral side and do a small opening, and then we can in one side and trying to do the first tunnel. So in order to enter the endoscope from the oral side to the anal side, it's a little bit tricky, this specific case, because of the, as I told you, the narrow space. Okay. Of course, sometimes it's very helpful, the water immersion technique that Professor Despo has invented. It's fantastic sometimes. And this is the end of the first tunneling. You see how the tunnel, inside the tunnel, the endoscope, the position of the endoscope is very stable, have a very good dissection plane. If you're trying to do oral dissection, incision, and then dissection in the whole perimeter, the whole specimen is going to flip, so that you don't have a very stable position and a good dissection plane. And then we proceed to the second tunneling from the opposite side. Okay. And this is almost the end of the second tunnel. You see how nice dissection plane we have with the tunneling technique. This is the end of the second tunnel. Nice, good. So what is left is the lateral submucosal. We try to do some small dissection areas of the lateral edges, but again, the whole specimen will flip. So I think that the best solution is to cut the cutted edges with a clip line method, and then have a good retraction of the specimen. And in this way, it's very, very nice and very, very easy to have a dissection plane, a very controlled ESD in this manner. Okay, I will go a little bit further. Nice. And in some cases, it's better I find it best solution to use IT Nano in order to shorten the procedure more. You see, with the blade of the IT Nano, you can have a very controlled dissection in a high volume of fibers. And of course, the ceramic tip is preserving the muscular layer not to be perforated by accidental movements. Nice. And then we proceed to the other lateral margin. This is the last fibers we dissect. And this lesion, I had the best thoracic surgery behind me as a surgical backup. He had an esophagus surgery for esophagus in the next room, and he went to his surgery after seeing the whole ESD, because as he told to his surgeon colleagues, I will never see these things again. It's something fantastic, even for the surgeons, to see how we can completely and unblock, dissect this kind of lesions. So this was about the upper GI techniques. I would like once again to thank you about the invitation, that I'm very glad to answer, if I can, any of your questions. Thank you.
Wow. Amazing presentation, Steven. Thank you so much.
You.
Unfortunately, you cannot hear any applause, but
no applause.
Please. Thank you so much.
Thank you too.
Okay, so for our attendings, please, if you have any question, feel free. And also, if you are not comfortable, you can just go in Spanish and we translate. But to open the discussion, Stefanos, I would like to say that you have told us that you begin 9 years ago with 3 months stay in Japan. And after that, you stay for 1 year, 2 years after your initial experience, and then 1 year more. And of course, I know that you have been in contact with your professors all this time. So this is very important message for the young endoscopist. This is not a thing that you just begin. You have to put your heart, your soul, and all your effort to gain experience with the real masters in order to do properly. So this is the first point, I think. And also, there are so much important things that you can see by just observing the masters. Usually, young endoscopists want to take the scope immediately and practice, but you have to watch so much, but watch carefully. In your videos, for instance, you have shown many tips, but you need to see these videos 100 times and again and again and again, and you always learn something new. For instance, you do something that I usually do, that use the near focus for better look of the fibers when you are very close to the target. But I am sure that many young endoscopists maybe can see this video by 50 times and they do not aware. They are not aware of this. So it's so important to watch the masters again and again, because there is always a new thing that you can learn. And also, I would like to ask you something. Usually, beginners want to use a small cap, like an ST hood or a long ST hood. But you have performed in a very narrow space, like the esophagus, a completely ESD with just a standard cap. So this is the concept of the trimming. The trimming is so important because in order to make a flap, you need to understand the importance of trimming. It's not the cap. If you have a narrow cap, but you don't perform the trimming, you cannot perform a good ESD. What do you think about this?
Well, this is a discussion every time. What is the cap you are using? So much words about details like this. Of course, the ST hoods, it's a conical cap. You can easily enter the incised mucosa. But after this, it's not so easy, because the knife is very far away from the field of view. So sometimes you cannot see what you are cutting. It's a little bit deeper than the straight cup. So you can imagine what I'm trying to dissect. If you do a better trimming, and then trying to enter with the straight cup, and of course you can use some other tips and tricks like water immersion. It's very easier to get inside with the straight cup. If you enter with the straight cup downwards the mucosal flap, then things are very easier than using SD hood. Of course, SD hood has his own advantages. Mainly, I'm using SD hoods in a very special location in the colon sometimes. But for the upper GI, I've never used this kind of cup. Never.
Yes. So I would like to ask to our very good friend Edward if he can offer some comments. Please, Edward.
Hello, hi Stefanos, hi everyone. Thank you so much. This was a lovely presentation. I thoroughly enjoyed it, and I must congratulate you on the great work, especially with that squamous lesion. Very impressive, and the versatility of using different knives. I mean, one can be limited in how many knives one can purchase, but it is very beautiful to see that the combination of different knives can actually make the difference, especially when you've got a ton of fibers. It makes it quicker to be able to switch. I am an advocate of the SD hood. As you know, I am of the school of Professor Yamamoto, and although I definitely recognize what you're saying, and I agree with you 100%, if you are using the pocket creation method, it is designed for that. But that doesn't mean that it is the only distal attachment. And I think, again, one has to tailor make the distal attachment to the situation as you learn in this very long journey, because each one of us is still learning, because every case teaches you more. You understand that ESD is about versatility, about being able to adapt everything together and to change the technique according to the situation. Thank you for mentioning the saline immersion technique. This is something that I discovered serendipitously. So in my unit, I was using mostly a 290 Olympus gastroscope. And as you know, the channel is 2.8 millimeters. So when I put my flash knife down, I couldn't suck. I could not suck because it obscures everything. So in order to suck, you have to take it out, suck again, push it down, and it was crazy. So I started using some water, and I realized that with water, although I get a better view and you get the buoyancy, the knife did not cut so well. So I changed it to saline, and that improved the cutting so much. As you mentioned, Andres, the near focus is very useful, especially if you combine it with immersion technique. So if you're in saline and you switch on near focus, you have a double zoom, because the fluid gives you already a zoom as if you're snorkeling in the Maldives. While with the near focus, you see everything in so much more detail. And it's especially important to not damage the vessel and cut. So I'm really happy to have attended. I really enjoyed that lecture, and I am really thoroughly impressed by the progress. It's not just in Japan, but also all around the world. Thank you.
Thank you so much, Edward, for your comments. I would like to say to all that we have the honor to be here, of course, with Edward, with Steven, and also with Fatih. But now we are with Professor Tsukasa Ishida and also Professor Noriya Uedo, who is just entering now to the room. So thank you so much, Professor Ishida and Professor Uedo, to be with us. Of course, they just connect, so we will ask them comments for the next lecture, as we will just they just enter now. Okay, so Steven, thank you so much. And also I think that 700 cases is an amazing number. You say it is not so nice, but I think it's wonderful.
It seems a very high volume of cases, but actually it's not. The cases are much more, the incidence is much more higher. After 2 or 3 years after practicing ESD, most of my cases were referred to me from surgeons, which was not the best thing, of course, because most of them were invasive cancers. But after learning all the endoscopic community, of course, what is the diagnostic of the early lesions, cancer lesions, and this was the bet. The bet is not to dissect the lesion. Dissection of the lesion can be performed by, let's say, in my country, in 2 or 3 or 4 centers. In Great Britain, in 20 centers. But diagnostic, how to detect early lesions, is a matter of all endoscopists. So yes. I think that the evolution of the endoscopic imaging, and of course the training of our eyes, will lead us to a high volume of cases. Okay.
It is so important what you have said. Yeah. Usually people that do not understand about endoscopy think that the expert is the one who is called to diagnose the lesion. But we know that all of us are called to diagnose the lesion.
Of course.
All of us. Yes, so important. Please listen to what Steven has told us. Thank you so much, Dr. Bassioukas, for wonderful, amazing presentation. Thank you so much. Okay, so now I would like to invite again to Dr. Fatih Aslan. As I have told you, he is from Turkey, and he is a one-of-a-kind ESD performer. So it's such an honor to have with us. And I have kindly asked to Dr. Aslan to talk about colorectal ESD challenging cases. So please, Dr. Aslan, you can begin your lecture. So you need to activate your microphone, Fatih. I'm not sure if he's listening. Just a minute. Okay, maybe Fatih is not listening. Let me look. Okay. Fatih, do not rush. We are waiting for you. Please just put your microphone on. Maybe Francisco can help you. Okay, I think you're...
Okay, can you hear me?
Perfect, please.
Okay. Thank you so much for kindly invitation. I would like to thanks to organization Andreas Durante and Latin America Group. Today, and as a second lecture about the colorectal ESD, Stefanos said before, how is the education for ESD? Briefly, I would like to share my educational process. And we have the first started to perform endoscopic mucosal resection in 2011. And 2012, we have continued to perform EMR, and we have gone to some Japan centers and Europe centers, the first ESD. And then I started to perform gastric ESD cases and rectal ESD cases. And 2013, I visited again the Japan, the different center, Keio Medical University and Jichi Medical University, and additionally POEM procedures. And 2014, 2015, and 2016, I visited again the Japan Center for the update ESD because ESD have continued to develop. And 2017 and 19, I attend to advanced endoscopic meetings, for instance, London IAM, maybe Düsseldorf Endolive, or Japan Yokohama Endolive. Unfortunately, 2020, we have not go anywhere because of the coronavirus. 2012 and 2020, 3,000 EMR and 1,800 ESD cases, and Zenker diverticulum, classic type, and peroral endoscopic myotomy, 900, and star-poet procedures, 70 or 80 cases, and POEM, Z-POEM, and endoscopic full thickness resections, and finally laparoscopic surgery, LEX procedures. And start with the lectures, ESD is minimal treatment, and there are some advantages. Primarily, it has precise histopathologic diagnosis, low morbidity and mortality. Additionally, short hospital stay, cost-effective and high quality of life compared to surgical treatment. But there are some problems for two treatment modalities. The problem of the surgical treatment, high morbidity and mortality and high cost and low quality of life. The other pan, an endoscopic treatment pan, there are some problems such as adverse events, which is the perforation or bleeding and possibility of residual lesions or lymph node metastasis. So which is the best strategic treatment, and how should we decide for the best treatment modality? Yes, ESD is excellent minimal invasive treatment, but in the Western countries, both the en bloc resection and complete resection rates were decreased and complication rate were increased. But why? And how can we do it, and how should have been done for the successful ESD? For the successful ESD, there are three important points: patient, equipment, and physician. Of course, both training approach and long-term experience are important points, but these important points differ from mostly Japan or the East Far countries. For instance, there are some differences in Japan patients, such as short colon, and additionally, Japan patients have much upper GI lesions. Additionally, the Western countries, the upper GI cancers, generally undifferentiated type lesions, and the East countries, those kind of the lesions has the well-differentiated adenocarcinoma. In Western countries, there are a lot of colorectal lesions, so ESD procedures in the colon may be difficult because approach to lesions and take the position and colonic wall and anatomic localizations. Additionally, there are a lot variety of equipment in Japan, such as the different knives, different scopes. These differences have been affected the quality of procedure, such as the procedure time and high quality specimen. There are sort of the scopes. Gastroscopes have good maneuverability, but as I said before, size of the working channel is 2.8 millimeters. So suctions maybe become difficult during the insertion instrument. For instance, flash knife or the other type knives. The new ESD scopes in the East countries have a 3.2 millimeter working channel. Additionally, the other scopes are multi-bending scopes, but those kind of the scopes is very expensive. The other problem, there are sort of the knives, needle type knives, insulated type knives, scissor type knives, but old needle type knives were classic knives without the injection capabilities. But now most of the needle knives have injection capabilities. Use of these depends on the endoscopies. My preferences are dual knife jet in my most of the procedures. The other option is carbon dioxide insufflator is rapidly absorbed by the GI mucosa. CO2 is absorbed from the GI tract, approximately 160 times faster than nitrogen and normal room air. So CO2 insufflation was associated with the less post-procedure pain and distension, and the CO2 insufflation was associated with the lower sedation requirements as well. As I said before, the endoscopic caps is the other differences. There are sort of the endoscopic caps. So as you see here, soft caps and conic caps. This is very important. Generally, caps provides a safer cut, traction, and when the arterial bleeding is encountered, to gain time, pushing is done the area of bleeding with the cap. Therefore, submucosal area is prevented to become dirty. So clear submucosal area is very important, the safer and faster procedure. But different endoscopic caps and soft caps and straight caps and conic caps is different. Generally, straight caps are soft and they don't give the knife's direction. Conic caps are hard and give the knife's direction. This issue useful in is especially severe fibrosis. So target area and submucosal area is easy to approach. How is that? As I said before, a soft and straight cap don't move knife. The knife directly approach to submucosa. As you see here, the image, the straight caps have different A and B distance, as you see here. And the other image, as you see here, the distance of the A and B very similar. So this helps to approach the area of interest. This reduces the risk for accidental mucosal injury or muscular injury. The disadvantage for these caps, conic caps, unfortunately, they easily blur the image and they limit the visualized area of the camera. There are two different conic caps in this here. One first image, it's easy to access the target area. This image from the Hironori Yamamoto colon ESD books. And the second image, the target tissue is tissue is approached but not close the first image. Finally, soft caps approach to this area, and the conic caps approach the closer the target, but the other conic caps is very closer the targeted area. The other problem is in the colorectal lesions and the injection solutions. As you see here, and Stefanos said before, the submucosal tissue is very thick in the gastric area. Unfortunately, the colonic submucosa is very thin. Additionally, colonic submucosa very soft. So we need to injection during the colorectal ESD. So there are a lot of solutions for submucosal injection, but it's important to make the injections the long-lasting effect. According to studies, the hyaluronic acid and hydroxypropyl methylcellulose and hydroxyethyl starch and gelafusine have a long-lasting time. Generally, I have preferred to use hydroxyethyl starch and gelafusine solutions because my cases have big lesions, so we need to a lot submucosal fluid injections. So this is equipment is okay, but what and how should we do it the colorectal lesions? It is important. It has to be true diagnosis, invasive or intramucosal cancer, and it has true indications, endoscopic and surgical treatment, and it has to be true treatment modality, polypectomy, EMR, endoscopic piecemeal mucosal resection, or ESD. Importance of indications. Is it sufficient to classify only by the lesion size? As you see here, three picture image, even very small lesions can be invasive carcinoma. This is colon lesions and 8 millimeters. This case referred to surgery and T2 invasive carcinoma. The other case, 18 centimeters lesion located on the rectum. This case, finally, tubulovillous adenoma. So, how to decide for resection? This is important point. How should characterization of the lesion be done? VLI and acetic acid and immersion and electronic chroma-endoscopy diagnosis correctness 60% and 70%. With better diagnosis with the chroma-endoscopy and magnification up to 90%. We have two videos, as you see here, left picture. These male patients, lateral spreading granular mixed type lesions, according to VLI examinations, only protruded area was seen. But with the electronic chroma-endoscopy, in the large nodule, vascular and surface pattern abnormality were clearly seen, as you see here. Additionally, MBI is provided to delineation in the colorectal lesions and esophageal lesions. And with the near focus very help to characterization of those for those kind of the lesions. As you see here, this area, vascular structures and surface pattern were regular, but in the large nodule have generally irregular pattern were seen. For these lesions, the best treatment strategy absolutely ESD. After the indicocarmine delineation is clearly were seen. The other lesions located rectum, circumferential lesions, but in the VLI examinations, no invasive pattern, but sorry, in the NBI examinations, the lesion started to rectum, extended to rectosigmoid angle, probably 15 centimeters. With the NBI examinations, this area surface pattern and vascular pattern irregular, and surface pattern, some of the area that were absent. And with the retroflex position in this area, vascular pattern and surface pattern were absent. These lesions is absolutely invasive carcinoma, so chemoradiotherapy and then surgical treatment may be done, should be done. Okay. As a conclusion one, lesions should be identified with their borders, and advanced imaging techniques should be used for the accurate staging, and one should be well knowledge regarding the tools and equipments. Okay, which lesions should be treated by endoscopically and which endoscopic method should be used? As you see here, 4 picture and 4 different shape, 4 different polyps. Lateral spreading granular type lesions, protruded type lesions, and mixed type lesions and pattern irregular and absent, and non-granular type lesions. Of course, lateral spreading granular type lesions, EMR may be good options, but recurrence problem. The other lesions, EMR may be options, and absolutely, those kind of lesions, 3 pictures and 4th pictures, ESD should be done. But ESD is, there are some problems. Lesions might be large, lesions might be placed on the and between folds. Lesions might be fibrosis from the previous procedure or from characteristics, as you see here. Bleeding tenderness from comorbid and anticoagulant use and lesion vascularity. So ESD can be hard and can be with risk for the complications. At first, the tips and techniques from the Yahagi slides, using gravity is very important because so we have a better use of everything. Gravity is very important assistance if the truly used. Gravity provides the better field, Therefore, submucosal dissection can be safer and faster. The other slide from Yoshiaki Hayashi from the Jichi Medical University sucked the gas to make the wall tangential. How is that? Sometimes lesions will be in the difficult localization, such as the behind or between house rods. When the excessive gas use approach to lesions, it cannot be easily. When the sucking the gas makes the intestinal wall tangential. So position of the lesion can be changed. So approach to lesion can be safer and easily. The other problem is too much air stretches the colonic wall and makes the submucosa thinner. So suck the gas to keep the submucosa thicker. Therefore, advanced events such as the perforation will be less. Additionally, suck the gas to make the intestinal lumen smaller, which keeps the endoscope stable. This issue prevents the abnormal scope movement, because paradoxal scope movement can cause the adverse events, such as the muscle injury, perforation, or inadequate submucosal dissection. The other problem, mucosal edge, can be solved. Mucosal edge receives strong upward traction. A longer lesion side edge allows for greater traction. In addition, it can lift up the branch of the blood vessels and fatty tissue from the dissection line. This provides better elevation and facilitates better and high quality submucosal dissection. These tips, and there are some advanced techniques. There are conventional techniques, circumferential or semi-circumferential, or traction techniques, clip with line, as I said, for Stefanos Bassioukas, and the other techniques, SOE clips, clip flap, yo-yo, rubber band techniques, overtube, ORICE system, Lumendi system, endolifter use, and the other new and practical techniques, pocket creation techniques, tunneling techniques, and multiple tunneling techniques. Conventional ESD techniques are basic. This is named the standard colorectal ESD techniques. According to gravity, circumferential or semi-circumferential is made, and according to gravity, step-by-step dissection is made. The other techniques, at first, particularly in the fibrotic lesion for effective and safe dissection, pocket creation method has been developed from Jichi Medical University. At first, mucosal incision is performed, and then from there we reach to submucosal layer, and then all of the submucosal layer is dissected under the lesion, and then finally mucosal incision is connected and completed. But when the lesion 5 centimeters or large lesion and biggest lesions, the other techniques is single tunneling method. Particular for large lesions, similar to pocket creation, but not all submucosal area was dissected. Mucosal incision is made, and then a tunnel is opened until the other end of the lesions, and then according to gravity, lateral incision and dissection are made. Pocket creation method and single tunneling method need of the hemostatic forceps with this technique will be less. Why? As you see here, which vessels should be coagulated in here for effective bleeding control. This is the main vessels. This is the branch of mesh vessels. Absolutely isolate the vascular structures instead of the small branches, decrease the bleeding change. How is that? The lesion is here. This is the submucosal area. This is the muscularis propria. This is the main vascular area. This is the branch of the vessels. When the standard ESD techniques, generally we encountered small vessels or branch of the main vessels. So these structures can be easily bleed. So it's need to coagulation many times. But In the tunneling method or pocket creation technique, at the beginning of the ESD procedure, this area will be passed easily, and then main vessels will be identified. So in this way, main vessels are coagulated by hemostatic forceps, so bleeding will be less common. This case is 72-year female patients. The lesion located on the splenic flexura and LSD G-type lesions. Generally, we have preferred to use the gastroscope in the left side localization, but for these lesions, I prefer to use pediatric colonoscopes, because the pediatric colonoscope is thin compared to the standard colonoscope, and I prefer to use the Fuji caps, as you see here. And this is very important. At first, the mucosal incision was done the anal side, and step by step proximally open the tunnel. And splenic flexura is very difficult because according to data, colorectal complications, especially perforation, have very often seen the splenic flexura or hepatic flexura. My results is similar. But in this case, no perforation was seen. And at first, the anal side to oral side, the tunnel was opened. And then according to gravity, lateral part were dissected. Finally, probably 80 or 90 minutes, procedures was completed. With retroflex position, generally pediatric colonoscopes provides the retroflex position. The lesion located on the splenic flexura on the 2 or 3 folds. And finally, procedure was successfully completed. And 92 millimeter case, multifocal intramucosal carcinoma with the tubulovillous adenoma, and procedure time 75 minutes. The other case, 63 years female patients, the lesion located on the ascending colon, proximal ascending colon, and closer the ileocecal valve. Those kind of the lesions, I prefer to use pediatric scopes and SD hood. Those kind of the lesions start of the procedure to oral side with the retroflex position. Sorry. With retroflex position, after the submucosal injection, dual knife was used. Generally, by prefer to dual knife jet, and for the submucosal injection for this patient, I prefer to use hydroxyethyl starch. And step by step to opening the tunnel with the retroflex position, and then scope is the straight position, anal side and oral side will connect it, and then finally tunnel was opened. Those kind of the lesions generally is gravity may be changed. Additionally, after the tunnel, opening the tunnel, for the lateral part to dissecting, patients may be positioned. Patients may be changed position. Finally, the lesion was completely, procedure was completed, and the lesion was completed. Finally, the procedure completed, and the lesion located on the 2 or 3 folds. No perforation was seen. About 30 centimeters and it was reported as multifocal intramucosal carcinoma with tubulovilous adenoma. Procedure time 84 minutes. The next lesions is located on the rectum. The patient, 60-year male, presented with the diarrhea. LSD-G was found in the rectum to extend on the proximal rectum. According to MBI and chromoendoscopy, all of area was examined, and vascular pattern and surface pattern were regular. For this lesion, our strategy is that, as you see here, the lesion very close to the anal canal. At first, the mucosal incision was made, and then opening tunnel, and then proximal dissection. Sorry. And then, according to gravity, left and right part incision and dissection was made. Those kind of the lesions, generally I have preferred to anal canal to extend to proximal rectum, but anal canal is anal canal site is have very rich vascular area. So when this happens to dissecting, generally we have preferred to use coagulation mode and sieve coagulation or power coagulation, the ESG 300 model for Olympus. As you see here, muscle layer clear. And submucosa is here. Those kind of the techniques, this method is providing the big advantages in the order to isolate the main vascular structures. Main vascular structures is here, so bleeding is less common. So these vascular structures can be easily coagulated and easily cut the same knife. Finally, the opening tunnel was completed, and then change of the position, the patient's lateral parts were dissected. After the procedure, as you see here, a little bit retain the mucosal layer. The other part will dissected and removed. Finally, 21 centimeters tubulovilous adenoma with focal high-grade intraepithelial neoplasia. Procedure time 228 minutes. So these techniques, the first time Digestive Disease Week 2015, I presented, and the same year, 18 centimeters lesion, I presented again the single tunneling method, and 2016, the multiple tunneling method in the rectum in the ASGE World Cup endoscopy. So if you want, and the good strategy is provided, every biggest lesions can be dissected and removed from the colon. But the other lesions and the difficult lesions, ulcerative colitis and high-grade intraepithelial neoplasia, as you see here, this is the white light imaging and the MBI examination. And after the chromoendoscopy, as you see here, the lesion is here. For these lesions, ESD, circumferential ESD was done and complete resection was provided. The other lesions is LSD granular type lesions, and the same technique was used, and the deep submucosal dissection was done for prevent the structure after the procedure this area was closed with upper lower stitch endoscopic system. So finally, all of the lesions can be successfully completed. The other treatment modality is high fibrosis lesions. As you see here, PAM procedures. My cases are now 40 cases, and about these lesions located on the rectum, and finally circular muscle layer was dissected with the tumor, and T1A tumor was resected successfully. Sometimes endoscopic full thickness resection can be performed in the rectum. As you see here, gastrointestinal stromal tumor, and the standard ESD technique was used, and full muscle layer was dissected with the mesorectum, and then complete resection was provided, and after the procedures, the resected area was closed with the upper lower stitch system. Finally, take-home message for ESD and endoscopic resection. The keys for a successfully endoscopic resection includes an accurate preoperative diagnosis, and new techniques and equipments are good methods for envelope resection with short procedure. And the resection itself, of course, important, but the most important priority is always patient benefit. So far, as I said before, 1,733 ESD cases were done, and most of the cases colorectal ESD cases. Our results similar to Japan results. More than 10 centimeters lesions, 92 cases, and envelope resection and complete resection about 100%, and 20 centimeters, more than 20 centimeters lesions may be performed if you want, but accurate staging and circumferential ESD in the rectum can be performed if you want. On behalf of our clinic and from Istanbul, Turkey, thank you very much.
Thank you so much, Dr. Fatih Aslan, for amazing, wonderful lecture. You are truly one of a kind ESD operator. So it's a real honor to have you with us. Thank you so much. Yes, amazing. Have no words. So, but we have to carry on, and I don't want to. I just want to ask to Dr. Nori Yawedo some comments, because it is like 2 a.m. in the morning. So, Dr. Nori Yawedo, please, can you please give us some comments?
Yeah.
Please.
Hello. Can you hear me?
Yes, perfect.
So thank you for invitation. I just amazed. It's incredible. So I just want to ask, I think already this presentation is already far advanced, but I think a non-Japanese expert, most important thing is how to take off, or how to get the learning curve, or how to accumulate initial case volume. So I think, do you have any comment or good advice? I want to ask Faith to share your experience, initial takeoff of your experience.
I see exactly. At first, the first visit, when I was the first visit Japan, I have only performing the endoscopic mucosal resection. After the comeback to my country, I accumulated to 10 or 20 cases in the gastric area. These lesions located on the antrum, but unfortunately, as I said before, in my country, most of the gastric cancers of undifferentiated type cancers. So the decision is very difficult. Additionally, we don't have the zoom scopes in this time. So biopsy and then staging and then decision. At first, tubular adenoma or high-grade intraepithelial neoplasia or well-differentiated carcinoma in the antrum lesions. And then the same time, 10 or 15 case in the rectum, smaller lesions, 2 or 3 centimeters. And step by step, and then corpus, angulus, angle, and proximal area, and left side colonic lesions can be done. My preferences is done. Additionally, all of the cases I presented the international meeting. So different hospital referred to my hospital, and cases accumulated my hospital, and finally it is very lucky for me this time easily passing. In my opinion, every ESD performer absolutely every time visited the ESD Masters, for instance, Japan. So I prefer to use this method. So every year I visited the Japan centers, additionally Japan international workshops, as like the Yokohama Live or the other ESD workshops.
I see. Thank you. Maybe important thing is learning curve should be modified according to site by site, country by country, hospital by hospital situation, but like a step by step, and also continuous exposure, like visiting some expert center. That is an important key.
Yeah.
Thank you.
Can I do a comment, Andres?
So much. Yes, please,
Edward.
Edward. Please.
No, Stefanos. Andres.
Oh, Stefanos. I'm sorry. Stefanos, please go. Go.
Okay. First of all, I want to salute Ohio Gozamasta, Professor Uedo. Great honor to have also Professor Uedo. He's one of the pioneers of advanced diagnostic in endoscopy. So I think that first of all, to do all these kind of unbelievable things that Fatih Aslan has shown us, I think the first step to do all these kind of things and the evolution in non-Japanese area to do things like this was the enter of the image-enhanced endoscopy. Because we didn't know what was image-enhanced endoscopy. We thought that only a good virtual filter that's enough. It was not. I think that the enter in our daily practice, the simplest optical magnification we have in the West, that is dual focus, changed completely everything in the Western perspective. Of course, I find myself sometimes, I wish I had the series of Olympus endoscope they have in Japan, like Noriya Uedo is writing his unbelievable endoscopic atlas with this kind of endoscopes. But I think, okay, that's the dual focus, the enter of image, the optical magnification changed our life also in the West. And I think this is what is ESDs was very simple after detection of early cancer lesions. That was my comment. And of course, if someone wants to learn ESD, has to visit a Japan center. Also, my colleagues, my junior doctors I have in my hospital, I'm sending them to Japanese centers to see the work and actually the philosophy behind all these things. Okay, so thank you.
Thank you so much, Steven. There is again, so important points on what you said. There is you need to live the thing in Japan. You need to experience in all what that means, how they live, how they think, how they move, how they see the things in order to apply the real ESD. I would like to kindly ask to Dr. Tsukasa Ishida to open his microphone and also ask him for comments. He is a very good friend and a professor who is highly influenced by Professor Takashi Toyonaga. So I would like to ask him if he can share some comments about presentations. Please, Dr. Ishida.
Thank you. Thank you very much for Andres. Very impressive video. I'm amazing. Foreign, non-Japanese ESD procedure is very, very improved compared with 5 and 10 years ago. I'm very happy to see the videos. All videos maintain the good visualizations, so the very stable procedures. So my mentor, Dr. Takashi Toyonaga, always say the tips of the ESD procedure is the depth of the dissection lines is important. So he always say the just above the muscular propria, and then so the Dr. Aslan's videos always maintain the dissection lines just above the muscular propria. So many doctors watch the videos, and the Dr. Andres mentioned before. He watched the videos every time. So then repeat, watch the videos. So then image is improved by video watching. So the many doctors always the same levels, same images. Image is important for the ESD procedures. So I'm also during a young age, I watched always Dr. Takashi Toyonaga's procedures. So the first step is important for the watching good procedures.
Yes.
Yes. So I'm sorry I'm not the good English speaker, but it's important to master the ESD procedure. This is my comment. Sorry.
Thank you very much, Dr. Ishida. We could understand perfectly. Thank you so much for your kind participation and your comment. Thank you very much. So I think Dr. Edward Despot also wants to make some comments. Edward, can you activate your microphone?
And hello, Fatih, and thank you for such an amazing presentation. You not only impress us, but even the Japanese masters are thoroughly impressed by your work. It is unbelievable. It's as if you were born to do ESD. And your lesions are not lesions, but dinner plates. They're the size of a plate, I tell you. So it's unbelievable. I have a couple of questions for you. I think I may have asked them to you before, but for the benefit of others, I will ask them again. So in my mind and in clinical practices, we do more and more ESD in the West. We are not going to be as fast as Professor Wedo or even as fast as you, Fatih. You are very, very fast and efficient. And I think that is reflected by the numbers that you do, because the more you do, of course, the faster you get, but also your intrinsic skill set. As I said, you were born to do ESD. Now, when we do ESD procedures, what we don't talk about enough, I think, is the time it takes to do a procedure. Because as you know, in the West, most of our patients, unlike in Japan, we tend to do these with heavy sedation, with propofol, or even with general anesthetic. And if you have a patient who is elderly and is under the knife or under ESD for a very long time, you cannot just factor in the potential complications of the ESD procedure itself, but also of the general anesthetic or of the sedation. So I wish to ask you, number one, what is the longest time you've spent doing an ESD? What, in your opinion, should be a cutoff point in terms of time, not size, because then you introduce further risks? And my last question relates to your huge lesions. How often do you encounter strictures, and are they dealt with efficiently with repeated dilatations? Because as you know, whenever we dilate a patient, we are exposing them to further risk. Thank you.
Thank you, Edward. Okay, now the hard questions, Fatih. First, congratulations, and then the hard questions. Please activate your microphone. Fatih, maybe Francisco Schmidt can help us?
Yes.
Okay. Go.
The first, generally, the lesion size depends on the procedure time. Procedure time more than 2 hours, so anesthesia shape may be changed. Especially upper size lesions, esophageal size lesions, and big gastric size, cardiac localization on fundus or fornix and proximal gastric part, and more than 10 centimeters or 15 centimeters lesions. I prefer to use general anesthesia because my patients taking the alcohol and the liver function test is anesthetic drugs faster. So anesthesia division prefer to general anesthesia, but limited less than 5 centimeters lesions, colon or rectum or antrum or esophageal part. Pseudoanaesthesia, that's enough. Depends on the patients, depends on the localizations, depends on the size. I prefer to change to anesthesia. 2-3 years ago, I tried to spinal combined type anesthesia in the rectal lesions, which is the best choice. Probably 2 or 3 months later, I published the spinal combined anesthesia or general anesthesia. General anesthesia better. The other second question, after the big ESD, how often structures? Now, 4 cases I have seen the structures. One case is that 6 times the balloon dilatation. The other cases, 2 or 3 times balloon dilatation, that's enough. But now, for the big lesions, I prefer to use stir techniques with the Apollo over stitch system. With these techniques use no structures were seen in this now. Probably this healing is faster and no fibrosis, the fibrosis is limited. The other question, sorry.
I asked you about, do you have any time limit? Because even if you give a patient a general anesthetic, you have a risk from the anesthetic. So do you draw a line, let's say 3 hours? You cannot go longer than 2 hours.
More than 2 hours.
So you draw a line at 2 hours.
Yes, no. More than 2 hours. No, not stop the ESD. Most of the longest procedure, 9 hours.
Yes.
540 minutes.
I understand you, and that is admirable, and congratulations that you kept on. But my question is, do you have a time limit? Because we know that in elderly patients, if you give an anesthetic for a long time, you have a higher risk of complications, pulmonary emboli, sepsis, lung infections. We should have limits.
3 hours. 3 hours.
Okay.
Okay, thank you very much, Edward. Okay.
Thank you.
And also, Dr. Fatih Aslan, do you have any comments about the muscle retracting sign sometimes when we face large like polypoid-like lesions, we can, if you have enough experience, you can perform a very nice ESD, but then you face the muscle retracting sign, and things come to your mind like maybe invasive, maybe just fibrosis. Should I proceed or stop? Please give us some comments.
Okay. Protruder type lesions, generally muscle retraction sign may have been seen, but the vascular structure pattern or surface pattern was irregular or ulcer area. Probably these lesions have the submucosal invasive cancer. So when this happened, especially protruder type lesions and lateral spreading more than 5 centimeters lesions, I prefer to use for the rectal lesions, I prefer the abdominal MRI for staging, and then chromoendoscopy, and then rectal endoscopic ultrasonography. 3 point, the muscle retraction sign, this area magnify, probably highly suspicious invasive cancer, don't attempt. But 50-50, for instance, limited probably protruder lesions and movement depends of the fibrosis, I attempt to endoscopic procedures.
Okay.
At first, all of the colorectal lesions more than 5 centimeters and suspicious vascular and surface pattern abnormality. So staging is very important. Generally, I prefer to use staging radiological system.
Perfect. So we have 2 hours by now. It's very late for our Japanese professors. And also, I think you have to go with your families maybe. I just want to thank you all for attending to this meeting. It has been amazing. Thank you so much, Dr. Ishida, Dr. Uedo, for joining us. Thank you so much, Edward, for your comments. You are so good. So very good comments. Thank you very much for being here. I met you in Kobe. Do you remember? Some years ago. So it's amazing to see you again.
Yes, I remember you very well.
Yes, and also thank you all the participants to be here. I think it's so important that you know the real ones, like Edward, like Stefanos, like Fatih. It is important to know the people who really are making the art of ESD. So know them and hopefully visit them in their hospitals. And of course, visit Japan. You have listened to the masters say that they go again and again to Japan. It is important, go to the source, okay? And also, do not think you cannot do this. Of course, they are top performers and they do amazing things. But ESD is not about 25 centimeters. You can benefit many patients if you can properly perform ESD for, let's say, normal lesions. But you have to go to the source and really learn. I love music. And once Carlos Santana said, you don't have to be Jimi Hendrix in order to play the guitar. You just have to play with your soul and follow him. So you don't have to be like Dr. Toyonaga, Dr. Yahagi, or Fatih, okay? But you have to look what they do and how they do it and live that and feel passion for what we do, I think. So remember, we all can do it if we really love what we do. So I think this is my final comment. And again, thank you so much, all of you. And any final words, Steven?
Well, it was a great pleasure for me. Unbelievable your effort to do this thing. I really enjoyed it.
Thanks so much.
Meet my friend Fatih. Professor Despo, and of course our Japanese colleagues at that time. Right now, it was something unbelievable for me. Thank you very much, Andres. Congratulations.
Thank you so much. Any final words, Fatih?
Thank you so much. Great meeting in this time, especially coronavirus time.
Yes.
See you soon to the other meetings. I enjoy yours.
Yes, thank you very much. And I really hope that we can meet personally again. I know we will do it. So without any more words, thank you so much for coming and see you next time. Thank you very much. Thank you very much.
Thank
Goodbye.
you.
Goodbye.
Bye.